Good morning. Good morning, ladies and gentlemen. This is the multidisciplinary session dedicated to neuropancreatic endocrine tumors. And in this hour and a half, I will present this topic together with my colleagues from the University of Verona, and more precisely, Professor Claudio Bassi, who is the chairman of the Department of Surgery at the University of Verona, Policlinico Giambattista Rossi, and Professor Giampaolo Tortora, who is the chairman of the Department of Oncology in the same hospital. I will start with a brief introduction concerning the pancreatic neuroendocrine tumors. Pancreatic neuroendocrine tumors are divided into two categories: those which are associated with a functional syndrome, the functional PNETs, and those which are not associated with a distinct clinical syndrome, the non-functional PNETs. The diagnosis of the functional PNETs requires the demonstration of an elevation of the specific serum hormonal marker, that is, gastrin in Zollinger-Ellison syndrome or insulin in insulinomas. Secondly, it requires the clinical laboratory evidence of oversecretion of the appropriate hormone. Functional PNETs are rare. Their incidence in the case of insulinoma or gastrinoma is estimated to be 1 to 3 per million inhabitants, or 0.5 to 2 per million of inhabitants. These two are the relatively frequent tumors. The other are very rare tumors like lipoma, glucagonoma, somatostatinoma, and so on. The incidence is between 30 and 60 years for insulinoma, somatostatinoma, and lipoma, and between 40 and 70 years for gastrinoma and glucagonoma. Concerning non-functioning neuroendocrine neoplasm, in these there is no hormonal hypersecretion, or whether some of them may show immunohistochemical positivity for hormones which are produced but not secreted, or which are clinically inert, such as pancreatic polypeptide, or whose serum concentration are insufficient to induce symptoms. From the experience of our surgical department of Professor Bassi, we have a total of almost 500 dissections performed from 1990 to December 2013. And as you can see, the number of non-functioning tumors is much larger than that of functioning tumor, 77% versus 33%. Among the functioning, there is a predominance of insulinoma, secondly, gastrinoma, and other tumors. And this experience is similar to others reported in the literatures. These data are taken from a paper from the United States, in which you can see a definite increase in the number of these tumors, with the number of non-functioning tumors, the gray one, are much larger than that of the functioning tumors. So, concerning non-functional PNETs, the last WHO classification divides this tumor into well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. There is a further distinction between NET G1, G2, and G3, which is based on the level of Ki-67 index, less than 2% in G1, between 3 and 20% in G2, and above 20% in G3. The same classification defines the biological behaviors of this tumor, which can be benign, low-grade malignant, and high-grade malignant, on the basis of the presence of metastasis, invasion, tumor size, angioinvasion, and of course levels of Ki-67. And as you can see, the major distinction between benign or low-grade malignant is the size, less than 2, greater than 2, while low-grade and high-grade malignant can have large size and the size can be extremely large in the case of this type of tumors. Of course, this grade are associated with metastasis, invasion of adjacent organs, angioinvasion. The annual incidence of non-functional PNETs is estimated to be 1.8 to 2.6, although in some series from Asia, this incidence is more important. The peak is in the 6th and 7th decade, with an increase of incidental detection of non-functional PNETs, and this is due mainly to diagnostic imaging modalities. However, in autopsy series searching for small, less than 1 centimeter, the reported frequencies are much higher, ranging from 0.8 to 10%. The symptoms, some of them are asymptomatic. In other cases, we will have symptoms which are related to the size of the mass, which cause compression or invasion. So we can have abdominal pain, weight loss, anorexia, jaundice, palpable mass. There is also association with the men, type 1, von Hippel-Lindau, and tuberous sclerosis. Concerning the prognosis, we have to consider that 32% of this tumor present liver metastasis at diagnosis. So the median overall survival is 38 months, and the 5-year survival rate is 43%. And these data are much greater than that we observe with pancreatic adenocarcinoma, where the 5-year survival rate is about 5%. So they have a much better prognosis, although they are predictor of poor survival, like the presence of distant metastasis and the degree of differentiation.